Oh.
Hello everyone, welcome again. Let's restart our
One train.
GIT Viva session again. Um, my advice is for all of you. I think your exam in 20 January. Exactly when, Dr.
Yes.
Nagam, you're now 20?
23.
Yeah. My advice for all of you, keep calm. I think most of you or all of you are doing and did his and her best, really. Again and again, the 2P exam is the exam of mindset and uh, mindset and your stability, your mental and nervous stability. Really, don't think about any negative feedback, about any negative circumstance, which specifically occur in the last October exam. Each exam has its circumstance. Two candidates enter the same exam and enter the same sets of Viva, one pass and the other one didn't pass. I don't know why, but I think all of you are different. You can pass. Now focus in the weak point, try to enhance it. Any system that you are have a doubt about it, be sure you will face it in the exam. So it is better to concentrate in the systems that you are not sure about yourself, like spine, like head and neck, whatever. This is two pieces of advices are very important. Let's start our first case. Today is GIT cases. Dr. Nagam, you can, I will scroll through or you.
Okay.
Okay. This is 60-year-old male patient presented with sudden onset of severe abdominal pain, tenderness. Go on. Request
Okay.
control, Dr.
So,
Nagam. Request
okay.
control.
Requested.
Yeah. But try to use the sidebar, this one. You can use the arrows. Okay.
Okay,
You
up,
can use
up and down.
Yes.
Okay. So, I'm presented with CT scan of the abdomen, axial cuts with IV contrast for a 60 years old patient presenting with abdominal pain. I would like to have a general look before starting my comments. Okay, so yes. I'm not happy with the appearance of the bowel loops. There are multiple small pockets of fluids seen within the peritoneal cavity.
Yes.
This is the end of the scan. So I will go back. There are multiple diverticuli, fluid level, free fluid within the abdomen. There are multiple segments of bowel wall edema and enhancement. There is area of concentric bowel wall seen in the middle of the abdomen to the left, showing concentric bowel walls. The vessels are patent. The stomach is distended. The liver is unremarkable. I'm concerned about free fluid in the left upper quadrant. I would like to confirm this on the lung window. The esophagus is also dilated. So, given the presence of the diverticuli and the age, I'm thinking about diverticulitis. And given the over-distended stomach and the esophagus, I'm thinking about obstruction of the proximal GIT. And the presence of the free air could be due to perforation. So I would like
Where?
to go through all
Where?
these, the free air.
Yeah, where's the free
Okay.
air? Show me.
Okay, I'm not happy with this area. And in the upper part of the abdomen, also, I'm suspecting a pocket of free air. I would
Where?
confirm it on the limb window. Here, on the very anterior
Yeah.
parts.
Okay.
So
So,
yes, to me, this is pneumoperitoneum. So I'm concerned about perforation. I would like to search for the site. At this
yes.
point, I'm thinking the cause could be diverticulitis. I would like to check for the maximum
Where?
point
Where?
of
Where is the diverticulitis that you are suspect about?
okay, here there are a lot of diverticuli, so I would like to
Mhm.
search for the maximum area of fat stranding and maybe
Yes.
collection that may indicate a perforated diverticulus.
Mm-hmm.
Okay, I'm not happy about this appearance at all. Is it connected to a bowel or it is just a collection? Just I would like to make sure.
Which one?
So this is this area. It is has
What
abnormal
is this?
appearance.
What is the name of this structure?
Okay, seems it is not connected to the bowel. This is collection. This is collection with enhancing wall with internal air
Follow it, please.
pockets.
Please,
So this is the
Dr. Nam.
anaphysis.
No, no, no.
Yes.
Follow this structure. Follow.
Okay.
Back.
Okay. It is
Follow.
appearing here.
Yes.
Okay.
Where? Follow. Follow again. Again.
Okay.
What is this?
Okay. So okay,
Is
just
this collection or
okay.
collection
It
beside a
is
bowel?
okay. It is ending here, and the other end is continuous with the small bowel. Yes, it is. The other end is continuous, so it is a collection beside the bowel.
Oh.
So this is an abscess. To me, this is could be due to the site of the perforated diverticulus that
Mhm.
causes the free air and the fluid and the inflammatory change between the abdomen and the cause of the patient presentation. This is an emergency for urgent surgical referral for the pneumoperitoneum for further surgical treatment and follow-up.
Okay.
In my routine
What
practice, yes, I will
else?
check the lung window and the bone window. So given the over-distended stomach, again, I would like to check for the schools. I'm suspecting elements of upper bowel obstruction. The bowel
Yes.
loops in the lower abdomen are also not looking
What
normal.
other causes? What other causes of perforation of bowel? But the
Okay, it could be
question before it,
ischemia.
is it
Y-
a
Okay,
small or large bowel?
it is within the center, so this is a small.
Yes. Enumerate
Okay,
or mention the
okay,
cause, please.
okay, so it could be due to ischemia. It could
What
be
else?
due to hernia. It could be due to adhesions. It
No, no,
could be
in that
mechanical
case.
obstruction.
In
In
that
this
case,
case,
see. Yeah.
okay. Seriously, before every other possibility, I would like to exclude the most crucial causes, which is the vascular. So I would like to follow the vessels, superior mesenteric artery,
Don't worry
respiratory.
about it. Don't worry about it.
Okay,
If you know the exact location of this bowel or the name of this small bowel, you will guess the cause. What is the name or the location of this bowel? Follow it. Which part
okay.
of small bowel? No?
Okay, it is the duodenum. It is the third part of the duodenum, I think. Yes, this is the first. And this is the
Yes?
second, and this is the third. It should be passing between the aorta and the superior mesenteric artery. If it is compressed, then this is going to be the cause. It is distal to the aorto mesenteric angle.
So what do you think,
Uh,
what do you expect
this
the
is
cause?
the junction. This is the junction
Okay,
between the
what is the,
duodenum and the.
yeah. What is the expected cause for this bowel perforation specifically?
Okay, at this site, the commonest is the volvulus. However, this occurs in much younger age.
What else? What else?
Okay, so it could be due to, it's not typical, it looks like, however, not typical for interception.
What else?
And,
Are you
okay,
familiar? Did you see
adhesion,
before
internal hernia.
intersusception? Did you see before internal hernia or intersusception complicated by Perforation? No, unlogic.
No.
What else?
Okay, so I will have again another look and check for the any other possible cause.
I will help you. Repeat in your
It
mind.
is
Yeah. What is the cause of perforated duodenum?
ulcer. The most common is
Yes.
ulcer, and
Okay.
could be another cause is groove pancreatitis, or could be diverticulum, duodenal diverticulitis.
Confront the cause in this slides. How do you
There
think?
is an abnormal collection seen here beside the duodenum. It is
No?
peripherally
Don't
enhancing.
worry. Don't
Yes.
worry about it. The cause is in this slides.
Okay. In this slice, so I can see the pancreas, the stomach, the duodenum, the vessels are patent.
What
Okay,
happened
so
for the
again,
pancreas?
divertic.
What
The
happened
pancreas,
for?
there is an area of abnormal enhancement with maybe calcification. The
Okay.
pancreas, yeah, okay, annular lateral,
Yes.
or I would like to check for any pancreatic tissue on the other side of the pancreas that may be representing arrest of pancreatic tissue,
So
causing
what come in
annular
your mind?
pancreas with
One second.
obstruction.
One second. What come in your mind when you see this focal pancreatic abnormality and the duodenal ulcer? You should tell the examiner what is in your mind.
Okay,
Focal. Mm, yes.
okay, it could be an okay, it could be annular pancreas or diffusum, which is not really the case.
No, no, no.
This enhancing
Annular.
okay. This enhancing lesion may be
Yes.
pancreatic islet cell tumor, and this is Zollinger-Ellison syndrome,
Okay. So
causing
what's your next step?
multiple.
Yeah. What's
Okay,
your next step?
so it's okay. This patient firstly is for urgent surgical management. For
Okay.
confirmation for this pancreatic islet cell tumor, I would go for uh, endoscopy, biopsy, or octreotide maybe, as these are neuroendocrine cells, or nuclear study.
Okay. Thank
Could
you.
be part of Lynch syndrome. Okay, thank
Okay.
you.
Next candidate. Next
Yes, sir.
candidate.
Good
Yes.
evening, sir.
Doctor, yeah, good evening.
Good
Your
evening, sir.
colleague diagnosed this perforated duodenal ulcer in the fourth part of the duodenum, and hardly she picked up this focal pancreatic abnormality. This one. What is, in your opinion, your next step?
Um, okay. So this focal part, I saw that the patient was on proton pump inhibitors due to acidity for very long, sir. So I am thinking of a tumor in the pancreas or a pancreatic neoplasm, which is causing increased acidity in this patient. So I'm thinking in terms of gastrinoma or like Zollinger-Ellison syndrome, which is causing increased acidity, due to which the patient was taking proton pump inhibitors. And the ulcer, which is present in the duodenum, might be because of this increased acid secretions. So I would like to correlate with the prior films of the patient and also see if any prior CT scans were done in which this focal area of enhancement was present.
Yes, doctor. Doctor,
And
the question is very clear. What is your next step?
next step, okay.
What is your next
So
step?
next, yes, sir. So since this is an emergency, I would like to immediately inform the surgical team that there is a focal area of
Okay,
perforation which
your
is present
colleague,
at the foot.
your colleague mentioned that she will
Yes.
transfer to. Okay, but but what is your next step radiologically? Because there are a tumor.
Radiology.
Do you think it is
Yes.
better for that patient that he undergo an operation for the perforated ulcer and after 2 days? we do another examination and discover this pancreatic tumor and do another operation,
No, sir.
do you think it is the ideal? So there are some modality or examination should be done. What is the name of this? To delineate the pancreatic tumor. What is the name?
Um, uh, okay. Like next investigation of choice, sir.
MRI.
MR,
Yeah,
MRI,
it's
yes,
MRI.
MRCP
See, you
can be
have
done for this patient. Yes.
see, you have two choices. Either nuclear scan
Mm.
and it will take long time and this is emergency. So the other option is the most ideal. MRI. Very easy. Okay.
Yes.
Could you request control, please?
Yes, sir. I have requested, sir.
Yes. Okay. See, leave 1 second. 1 second. 1 second, please.
Yes, sir. Yes, sir. Yes.
This is T2. I think it is
Yes,
not
sir.
not the diagnosis. Okay. See, look here. This is diffusion. Okay. To
Mhm.
save your time. See, I give
Okay.
you diffusion.
Yes, sir.
Ask only
Yes, sir.
for another sequence. Only one
Yes, sir. I would
besides
like
the
to see
diffusion.
first diffusion followed by the post-contrast sequences to see the
Which
enhancement
phase?
characteristics.
Which phase of post contrast?
Arterial phase.
Arterial phase. Why not venous?
Sir, because these neuroendocrine tumors of pancreas are arterially enhancing tumors.
Excellent. Okay. So, 1 second.
Yes, sir.
Okay.
Mm. Yes, sir. So, I'm trying to visualize and
This is the diffusion.
yes, I
Go
can.
on.
Yes, sir. In the diffusion weighted sequences, I am. Yes, sir. I can see that there is a focal area of restricted diffusion at the site of interest in the
Yes.
body of pancreas.
Okay.
And I would like to see the same area on post contrast images also to see if it is showing enhancement on the arterial phase images. Um, well, I cannot actually appreciate a vivid enhancement which is present in this region, sir. In fact, I can see that the rest of the pancreas is showing relatively more enhancement as compared to that region of interest.
And
Um,
are you sure there are no
okay.
enhancements?
That focal area of interest in the body of pancreas, mm, no, sir.
Uh,
I'm unable
look
to.
again. Look
Yes,
again.
yes, yes, sir. Yes, yes. There is focal area of enhancement which is
Okay.
there. Yes, sir.
Scroll and show me.
Yes,
Scroll.
sir. So this focal area, sir.
Yes. So,
I feel
what's
that
your
is the focal
diagnosis?
area of enhancement. So
What's your
I
diagnosis?
feel it is a I feel it. I think my primary diagnosis would be that of a neuroendocrine tumor, likely a gastronoma, which is resulting in increased gastric acid secretions, resulting in duodenal ulcer formation, followed by bleeding in this patient, with the focal perforation of the duodenum and a pneumoperitoneum. So I would like to inform these findings to the surgeon about the presence of this neuroendocrine tumor for further surgical management.
Okay. What else should you do for this patient specifically?
So actually, for gastronoma, I think focal arterial enhancement, and then I'm not sure, sir.
Patient has
I think
pancreatic islet tumor. You should you should do something beyond the abdominal MRI. And you should do another thing inside the abdominal MRI itself.
A nuclear
What
study.
should? Okay, what else?
Um, Octreotide is for somatostatin receptors for neuroendocrine tumors. I think
What about
octreotide study.
what about
Yes,
what about the rest of the study? You diagnose the primary tumor. Your role
yes,
as a
sir.
radiologist not stop at this level. You should examine rest of the study, especially many cases of the Viva as a double pathology. Hmm. Okay. Could you have a
Yes,
look at the liver, please?
yes, sir. I have to look for
I'm helping
metastasis
you.
if any.
Yes, sure.
Yes, sir.
What happened here?
Yes, sir.
And what happened here?
Okay. Yes, yes, yes. There is a focal area of restricted diffusion which is showing enhancement on arterial phase images also. So, yes, this is metastasized to the liver also. So, it can result in yeah, yes, sir. It is a metastatic deposit which is noted within the liver. So, I think even liver as well as pancreas and spleen also have to be examined to see if any other metastatic
Okay.
deposits are noted.
There are a question you must ask yourself in islet tumors. Beyond
Mm.
beyond the abdominal examination,
Mm.
what should you do?
Urine metanephrine levels are seen and
No, no.
no, but for gastrinomas, no, sir. I think a nuclear study only has to be done. But I'm
Okay, what
not
else?
sure for
What else?
what else.
Hmm.
Cars can cause carcinoid syndrome. Then
Is this type of tumor has any association to any syndromes? Yes or no?
yes, sir. Yes, it is
What
associated
is
with
the name?
MEN2 syndromes.
What is your next step?
So I have to check for presence of any parathyroid or thyroid occurs like medullary carcinoma of thyroid if it is associated with Men's syndrome. Mm, then I have to look if there is any associated pheochromocytoma which is present in the adrenals. Also have to have a look at the medullary thyroid to rule out any presence of medullary carcinoma of the thyroid if any present.
Yes, so your next step is
Parathyroid-
hmm,
Pituitary. Okay, so pituitary. So to examine the pituitary and I'm having a look at the pituitary gland in the MRI brain and I would like to visualize the sagittal sequences. So okay, and the coronal sequences I can see that the pancreas this pituitary gland is can I have a look at the sagittal sequences, sir, if possible, because in the coronal I can, yes,
yeah,
it
what
is
do you think?
appearing normal in size. Yes.
Yes, do
So
you find did you find any
no,
microadenoma?
no, sir,
What
not in
is what is
pituitary,
this?
just one focal
What is
area
this?
of non-enhancement which is in the posterior pituitary gland. There is a focal area of non-enhancement which is there.
Or
Mm,
maybe hypoenhancing, and if we follow the dynamic, it will show delayed enhancement. Correct?
yes.
Maybe.
Yes, sir.
I think
Yes, sir.
because in pituitary we must zoom as much as possible. I think this area is not well. I
Mm.
think maybe have something here. Let's see the
Hmm.
radiomedia. See, yeah.
Microadenoma.
This area is microadenoma.
Yes.
Why? Because
Hmm.
what is the normal appearance of pituitary microadenoma?
Pituitary microadenomas are always late enhancing, sir. It will enhance delayed phases of image in the dynamic contrast as
Do you know
compared to
why, doctor?
macroadenoma, which is early enhancing.
Doctor, do you know why
Uh,
pituitary microadenoma enhanced lately?
um, I'm not really sure, sir.
Because it is
Sorry.
hypovascular. Hypovascular.
Hypovascular, right.
Like, see, my colleagues, any sarcoma delayed early and avidly. Okay? Any sarcoma.
Yes.
The opposite in adenomas. Adenomas is originate from epithelial origin, so it is hypovascular. Like also endometrial carcinoma, it is hypovascular. Pituitary microadenoma, it is
Yes.
hypovascular. Okay? Because
Yes,
it
sir.
is mainly epithelial tissue, mainly. So thank you, doctor, so
Yes, sir.
much. The final diagnosis is main type 1. What happened here, my colleague?
Type 1.
It may be a long case, but in long case, he will give you limited sequences, like 2 sequences in each exam. What happened here? We started with acute case, and our first candidate was all right when she discovered this pneumoperitoneum. But don't panic, my colleagues, when you find something at least strange for you. The atypical issue here is that there are something here not related to the typical duodenal ulcer which presented in the first word. Not here. And not in related to perforated diverticulitis, especially the patient is old age, 60 years. So think out the box. Duodenal ulcer and the perforation of the duodenum with contained, this is not contained, sorry, with pneumoperitoneum, because there are pneumoperitoneum here. Contained pneumoperitoneum or contained rupture means non-spreading. So think in another causes, perforated duodenal ulcer. So I ask candidate one to repeat in her mind the word perforated duodenal ulcer. After she repeat, she immediately pick up the answer. Oh, doctor, it may be pancreatic islet tumor. So the pancreas is one of the very difficult organ to be examined, especially in old age. Look here for any abnormality, even this focal calcification. I think there are another one here, this one. But at least if you pick up any one of them, the examiner will be happy. She told us she will do, she will transfer to the surgery. I think no. Before the surgery, MRI should be done. Why? Why? Because this tumor in the diffusion, I will give you one very great secret about the diffusion of the abdomen. Look at the spleen. Spleen and lymph node normally markedly restricted diffusion, markedly displaying restricted diffusion. When you see this one here, this is the diffusion, and the anatomical details are not clear. So almost you are presented with diffusion weighted images. There are one lesion here in the liver. There are one lesion here in the pancreas. There are one lesion here in the pancreas. So the most common is that pancreatic tumors metastasize to liver. So this is sorry, not. We should see the arterial phase because in islet tumors, arterial phase is the key. In adenocarcinoma, you can see the portal phase, and the adenocarcinoma will be seen as a hypo enhancing lesion. Because this is the early arterial, you must check the slightly late arterial. How can we differentiate both of them? Look at the hepatic veins, the contrast in the aorta, and just early in the hepatic veins. This is late arterial. Late arterial means 35 seconds. If you look here, see, this is focal lesion. This is not a vessel. And this is one of the mimics here. Unfortunately, the location was very confusing. Look at the tail. I think this is the tail. Okay. So the hepatic metastasis not seen well. I think maybe this one. But in diffusion, we are sure there are hepatic metastases. So our next step after surgery to rule out any syndromic association. Please, my colleague, there are very logic sequence in any pathology. Search for complication and search for any syndromic association. Okay.
Mm. Yes, sir.
Finally, it was a case of main type 1. Main type 1 means pituitary, parathyroid, pancreatic, 3P, 3P, 3P tumors, pituitary,
Mm.
pancreatic, parathyroid. Okay? And all
Yes,
of
sir.
you
Mm.
know
Yes, sir.
the rest of main type 2A, 2B. Okay, my colleagues?
Yes, sir. Thank you, sir.
Thank you. Thank you. Next, third candidate.
Assalamu alaikum, sir. I'm the third candidate.
Welcome.
Thank you, sir. Jazakallah.
Sorry. Why this case is closed?
Sir, can I ask for the control?
Give me 1 second. I want to share.
Sure.
Yeah. Could you see my screen?
Yes, sir. Ultrasound image I can see.
Yes. 60-year-old male patient presented with right upper quadrant pain.
Sir, should I be asking for the control?
After this ultrasound, I will give you control. What do you think?
So I've been presented with multiple focal spot images of ultrasound of a 60-year-old male patient who has presented with right upper quadrant pain. Here in these images, I could see that there's significant intra as well as extrahepatic biliary dilatation. The porta hepatis bile duct has been measured, and I'm trying to look for the measurement. I cannot appreciate any numbers on the screen to show me but it is dilated with intrahepatic biliary dilatation. In this focal spot image, liver appears to be normal with no focal hypodense lesion. The gallbladder is significantly distended with stagnant hyperechoic internal echoes suggestive of long-standing obstruction. However, the walls are intact without any evidence of gallbladder wall perforation in these images. Now, I would like to look for any porta hepatis or distal obstructing mass lesion in a 60-year-old male patient that is causing this proximal biliary obstruction. Um, Hello?
What is your next step and why?
So, okay. So if these are the spot images on these ultrasound images, I'm concerned for an obstructing pathology in extrahepatic region or centered over the bile ducts. I'll immediately inform the referring physicians as the patient is an obstruction and mildly would go into sepsis. The biliary system needs to be drained, and it can be done via percutaneous transhepatic biliary drainage or ERCP can be done.
So
However,
1 second.
the
1 second.
so
1 second. You will drain first, or you will do something before draining?
so MRCP should be done as well to rule out MRCP and CT abdominal pelvis with portovenous phase to look for any intraluminal calculus or extraluminal obstructing mass lesion.
I ask you to choose one, CT or MRCP.
CT abdominal pelvis with contrast.
CT is superior than MRI in case of biliary obstruction. Yes or no?
Sir, since it's a 60-year-old male patient, I'm expecting a mass and it's a long-standing obstruction since gallbladder. So I would want to go ahead with CT with contrast because MRCP would be without contrast. If
See?
Okay.
See, for your
Okay, sir.
knowledge, I will tell
Sir.
you two drawbacks of the CT. Some gallbladder stone are not visible by CT, especially those of low density. Next part, sometimes the gallbladder neck can't be also well visualized. Third, any mural thickening of the distal part of the CBD hardly seen by MRI. You can imagine by CT it will not be seen at all. The ambulatory tumors, distal CBD abnormalities, especially minor or early pathology, you will never see by CT because it is hardly seen by MRI.
Sir.
So finally, what do you think? CT is more superior or MRI in case of biliary obstruction,
MR,
especially non-acute. Suppose it is a chronic, like you said.
MR,
MRI,
sir.
MRI. Why? Because all stones, for example, will be seen as a filling defect, whatever the density. Okay? You know?
Right, sir.
Oh,
Totally
yeah, go
agreed,
on.
sir. Yes, sir, totally agree.
Go on. You can scroll.
So on these
I
these are
think
the coronal.
start with this one.
I'll request for the. Sir, I've requested.
If I will help you,
So
give the
I'll
mouse 1
start
second.
from the. Sir.
1 second. You can use the arm.
So these are axial T2 MRI images of the same patient where I can see dilated dilated intrahepatic bile ducts. I'm trying
Yes.
to look for the distal transition point of yes. There's a well-defined lobulated soft tissue intensity mass lesion centered over the pancreatic head, proximal to which there is
1
gross
second.
biliary dilatation.
1 sec. Where?
Sir,
Where?
sir,
Show me where.
can you, sir, can you see my arrow?
Follow it, please. Follow.
So this is the mass, and this I think is the bile duct. I'm trying to evaluate: is it periampullary, pancreatic, or distal biliary? Though
Could you have
pancreatic duct
another
is
look?
not dilated.
Doctor, could you have another
Sir.
look at the supposed mass?
Yes, sir.
River is black.
Yes. What do you think? What do you
Sir,
think?
can you?
Unmute yourself, doctor.
Oh, yes, sir.
Yes.
Yes. Can you hear me, sir? Yes, sir.
Yeah.
Sir, can you please hold it to the top where CBD is obstructed, please, so that I can evaluate if CBD is going through this or.
What do you think? Hello?
It, yes,
Yeah.
sir,
What do
I'm
you
trying
think?
to look. I'm sorry, the images are a bit lagging. Sir, pancreatic duct is not dilated, CBD is dilated. So my primary concern would be distal cholangiocarcinoma, primary biliary tumor.
Okay, could you have another look,
It is
please?
the images are not.
Doctor, have
I'm
another
sorry,
look
sir.
here.
Images. Yes.
What happened for the pancreas?
So pancreas is pancreas is diffusely enlarged with a loss of its clefts with some peripancreatic inflammation and stranding as well.
What does it
So
mean
this
for
can
you?
be so groove pancreatitis leading to inflammatory stricture of the bile duct, leading to uphill biliary dilatation.
Could you think groove pancreatitis will affect the whole pancreas?
No. But it is.
What is
Yes.
what
Whole
is
of the
the name of
pancreas.
this
So
sign?
is it interstitial acute pancreatitis?
What is the name of this sign of pancreatitis? Look again here. Look here. It is very specific appearance or picture of specific pancreatitis. Look, pancreatitis without
Sir,
fluid
the
collection.
images have just loaded of.
One by one, one by one, one by one. Pancreatitis, which the pancreas is
So this is diffusely swollen.
yes, with loss of digitation and nearly no fluid collection. What type
Yes,
of pancreatitis?
sir. Saus- Sausage-shaped pancreas with
Okay,
sir,
so
sausage-shaped pancreas representing autoimmune pancreatitis.
okay, okay, you are correct. This is autoimmune pancreatitis. According to the biliary dilatation, what is your diagnosis? First, you diagnose autoimmune pancreatitis, and then there are biliary dilatation. I give you chronal to help you. Do you think there are any obstruction here in the distal part? No, this is distal part.
Sir, there's a
Distal sign.
long abrupt stricture at the distal CBD, where the CBD shows abrupt tapering at the suprapancreatic part
What does it mean for you?
over
Autoimmune
here.
pancreatitis and distal abruption of the
Sir,
CBD.
autoimmune pancreatitis is associated with, yes, sir, cholangitis,
What's your final diagnosis?
inflammatory stricture and Sir, this patient has multiple findings of IG4 related disease process, including autoimmune pancreatitis and distal biliary cholangitis, leading to uphill biliary dilatation. And patient needs to be immediately, the findings need to be immediately conveyed to the hepatobiliary team as well as the referring physician for acute management. And the case then needs to be discussed in hepatobiliary MDT. The patient should also be screened for other stigmata of the IG4 related diseases, and IG4 levels should be checked as well.
The other stigmata of IG4.
Sir, the patient
Yeah,
can have orbital pseudotumor, mediastinitis, retroperitoneal fibrosis.
thank you, doctor, so much. So it was a case of IgG4. Why? Because IgG4. We have two items, autoimmune pancreatitis and sclerosing cholangitis. Why? Even here, if you have a deep lock here, the dilatation of the biliary duct is non-uniform, looks like beaded. Okay, so you have many differential. Overall, there are cholangitis, but which type of cholangitis? Is it uh, pyogenic cholangitis, extending cholangitis, or autoimmune cholangitis, sclerosing cholangitis? Due to the presence of sausage-shaped pancreatitis, okay, we are presented with a case of autoimmune pancreatitis and the autoimmune cholangitis, which is called sclerosing cholangitis. So the final diagnosis is IgG4. Thank you, doctor, so much.
Thank you very
Our
much,
next
sir.
step beside the screening of this patient, biliary drainage should be done. Doctor, do you think this patient is better to be drainage by stent or by PTC, BTD?
Sir, biliary stenting via ERCP because it's
Yeah,
sclerosing cholangitis and it's
yeah, because there are
that
no
would be a
distal
permanent
lines.
solution for the patient.
Yeah, thank you, doctor, so much. We are sparing the BTC, BTD for inoperable cases, cases which ERCP cannot pass through the ampulla of the trach. Why? Because external drainage has many drawbacks like infection, horrible infection. You open the abdominal cavity to outside. And this is, beside my colleagues, this is the BTC for people who interested in intervention. is highly associated with mortality rate. Mortality rate. So take care. This is not an easy, it needs expert. Thank you so much. Next candidate. Hello.
Yes, sir.
Salam. Doctor, this 55-year-old male patient presented with right leg pain and elevated ESR.
Okay. Can I take control or?
Yes.
Okay, I will ask.
Go on.
Okay. I am presented with the coronal T2 weighted images of a 55-year-old patient who has presented with right lion pain. I will go through the images before presenting my findings.
Yes.
I could see in the right kidney, there are areas of T2 bright signal centered in the renal pelvis with prominent renal pelvis as well. They appear to be connected to the renal pelvis. So I am thinking of a obstructive uropathy. I will just follow the course of the ureter down. I don't see any filling defect, but I can see that there is an area of kinking of the right ureter. It's not moving. Okay. It's
And you.
okay,
Yes.
thank you.
Where is the
Yes, so I
kinking?
can here. I see it going down and then it goes up and
Show
then
me
it
by
goes down.
the mouse, please. Show me by the
Uh,
cursor.
can you see my mouse?
No, it's not movable.
I will, okay, I
Anyway,
think the request, I will request again. I requested again.
okay.
Yes, here is the area of kinking that I saw.
Yes.
It's twisting up and then going down and then going back up again on the right side.
Could you know the name of this sign, please?
Um, hook. I think something related to that. I'm not,
Yeah,
I cannot
Fisher hook,
remember.
something like this. Okay. What does
Yes.
it mean for you? See,
So on
if
the,
you
yeah.
forget the name of sign, it will not a big mistake. But if you told the examiner the significance, he will be very happy. What's the significance or value of this sign? It's hooking
So
or medialization of the ureter.
on the right side, the hook sign is seen in cases of retrocaval ureter.
Okay, what else?
Can be seen in retrocaval ureter, or there may be a mass that is causing the medialization of the ureter that will result in a redundant area with proximal, or there can be stricturing.
Okay. Okay. So what sequence do you want?
I would like to see this in axial.
Okay. The name is very strange, really. Median waist sign. Okay, but at least there are medial deviation.
Okay.
Medial deviation. Okay.
These are the axial images of the same patient. And I'm
Doctor, take
following
this one.
the,
Take this one.
these are axial T2 images of the same patient. Again, I notice fullness of the right ureter, and then in the region of concern, there is medial deviation of the ureter. I
Yes.
am assessing for any, I can see there's a soft tissue intensity which is anterior to the aorta. I will follow it. Not sure if so it's not retrocaval ureter, it's anterior to the right. Uh, okay. It is an okay. It is anterior to the right IVC. I am just following to see if there is any mass associated with it. I can see that there is a small soft tissue intensity that is anterior to the aorta, where there is. Uh, it's very difficult to control. I'm sorry. Um, I will. Yes, I think there is a soft tissue density anterior to the aorta. It is encircling anterior to the left side. The left ureter, however, is in the normal position. Going down, I can also see there's extension of the soft tissue density on the right side, and the right main iliac vessel as well appears to have the same. In my routine practice, I would correlate this with the STIR T1 pre and post contrast, just to see if there's any enhancement or edema in this location.
What, what is the last sequence do you want to ask for?
I want to look, so next I want to evaluate it in maybe T1 post contrast or STIR if available.
The contrast. What do you say?
Okay. So these are T1 post-contrast images, and I can see that the soft tissue density that was present adjacent to the right common iliac, it is extending until the bifurcation of the right common iliac. And then, yes, so, and then I don't see it on the left side, and superiorly, it is, this is the last cut, superior. Yes, and superiorly, it is on the anterior aspect of the aorta. So I am thinking about retroperitoneal fibrosis, which is active because it is enhancing, and it is causing a mass effect on the right ureter with the upstream hydronephrosis. It is
What is
not.
your final diagnosis?
My final diagnosis is retroperitoneal fibrosis, which is complicated by hydronephrosis on the right side.
Okay. What else do you want to search in this patient?
I want to look at the pancreas. I want to look at the liver.
So you must perceive the examiner and tell him, doctor, the pancreas
Okay.
looks normal, or doctor, can I have a look? Because in the actual exam, you have the mouse, you can go up, down, zoom. You can do
Okay.
two things, zoom and go up and down. So
Okay.
if you, after your diagnosis, and my advice for all of you, because all the candidates of today, you are very good, but there are one minor technical mistake. You describe more and more the abnormality, which must be described in two sentences, and you must shift for other pathology, complications, syndromic association. So all of you, the four, today consuming the time which should be dedicated for covering the review area, implication, and the other associated findings. If I'm
Okay.
in your position, I will go to pancreas and do like this. Doctor, pancreas normal. Doctor, there are no any biliary dilatation. There are
Okay.
no, the base of both lung are normal. I'm excluding any association because retroperitoneal fibrosis is commonly part of IgG4.
Yes.
What is what is the common causes of retroperitoneal fibrosis?
The most common cause is idiopathic, but
What
secondary
else?
causes include drugs. There are certain
Like,
drugs that can cause retroperitoneal fibrosis.
mention one drug.
Mm, I think, I'm not sure. I think some chemotherapeutic drugs can cause it. I'm not sure.
If you are not sure why you insinuate yourself in a blind point for you. Hmm? Why? Why? Radiotherapy. Radiotherapy.
Yes. Okay.
Beta blocker.
Radio.
The most
Yes.
common beta blocker radiotherapy.
Beta block.
Okay.
Okay.
What
Okay.
else? What else?
Um, what are the drugs?
No, what other causes? We mentioned
Uh,
autoimmune, then idiopathy,
yes.
then drugs. Tumoral,
Yes. Yes. Okay.
like lymphoma. Infection, like what?
TB?
Yes, and
Yeah.
asbestos. So
Okay.
there are 5 common classification of any etiology:
Okay.
idiopathic, humoral, inflammatory, drug like this. And
Okay.
be more wise. Don't talk about something because sure the examiner will ask you in more details. Okay.
Okay. Okay.
What is your next step in this patient? What is
So,
your recommendation about this
so,
patient?
so for this patient, since it is enhancing, it is active disease, I will refer this patient to rheumatology for
What else?
um
Before you refer to rheumatology, do you have any something urgently?
yes, for the upstream hydronephrosis, I will
Yes.
I will consult urology
Nice to
for
meet you.
decompression.
Yes. So the immediate next step is nephrostomy to save this kidney. Thank you,
Okay.
doctor, so much. It
Thank you
was
so
a
much.
case of retroperitoneal fibrosis complicated with right-sided hydroureteronephrosis. Leave the mouse, please. Thank you. Next candidate,
Yes, sir. Assalamu alaikum.
Islam. Sorry. Doctor, this 25-year-old female patient presented with severe anemia, hematochezia.
Yes, sir. Okay, sir. Sir, should I ask for control?
Yes.
Okay. Sir, I have requested. Okay. Sir, I think yes, sir, I'm able to scroll the set of images. So, sir, I have been provided with the axial CT abdomen and pelvis, which has been acquired with contrast. I would like to scroll my set of images. Sir, I'm so sorry, it's lagging a little bit. Okay, sir.
I'm
Sir,
scrolling.
I've been,
Yeah.
sir, I was scrolling, but sir, it was running. It started running actually. Now, sir, okay. I would scroll a little bit slowly. So, sir, I have gone through liver and okay. And, sir, I think you are scrolling, sir. Okay.
I'm scrolling.
So, sir,
Okay.
I would,
See?
yes, sir, I'm not scrolling, sir. I'm not scrolling.
Yeah,
Sir, I
you can
think
use
I press,
you can use the arrow.
yes, sir. Uh, Sir, I think when I scroll down, it lags a little bit and then
Okay, okay.
starts
I
moving
will
with its
scroll
own
for
pace,
you.
actually.
I will scroll for
Thank
you.
you so much, sir. I'm so sorry. Sir, I've been provided with the CT abdomen and pelvis, which has been acquired with contrast. On the first glance, I can appreciate that there is a pathology which is likely appreciated in the left lumbar region. Uh, okay, over here, where I can appreciate that there is a circumferential wall thickening segment, which is related, which shows a central hypodensity area with a circumferential area of hyperdensity. I think it seems to be in communication with the bowel loops. I can appreciate there are a few air locules which are identified within the periphery of this lesion as well. I can appreciate vessels going within it as well. So I've been provided with a coronal set of sequences. I cannot appreciate the pathology up till now. I can, okay. There, okay. On these images, I can appreciate that there is telescoping of one segment of bowel loop within another segment. And I can appreciate that this is likely related to the jejunal bowel loops, as I can appreciate the large bowel loop is located further in the periphery. So I am thinking that this is a small bowel intussusception. And since this is an adult patient, so I would like to look at the lead point for this lesion, which I cannot appreciate any abnormal wall thickening. However, I can appreciate few air locules in the periphery, but I
Are
think
you
they
sure,
are related to the
doctor?
non-bowel.
Doctor, are you
Yes,
sure
sir.
are you sure there are no any wall thickening?
Sir, now I can appreciate there's the segment which is located outside. It is thickened, and it is most likely likely due to the edematous bowel loops, which might be a complication for this intussusception. But yeah, over here, sir, the internal bowel loops also appear to be very much thickened. So there might be a lead point or a malignant wall thickening, or sir, any kind of other pathology which I would like to follow up. And sir, I can appreciate normal enhancement of the peripheral segment. However, the central segment appears to be hypoattenuation. Sir, I am concerned about the vascularity of this vascular compromise of this intussusception. So, sir, considering these things, I would like to urgently inform my referral. First thing would be about the vascularity, and the second thing would be about, sir, to resolve the intussusception. Sir, there is no proximal obstruction which I can identify, sir, at this time. But the
What
vascular
else?
compromise is
Doctor, what else? What else?
yes. Okay, sir. Sir, the liver I can appreciate shows a rather heterogeneous pattern of enhancement, but I can appreciate that the port vein is normally specified. Um, Sir, liver, gallbladder, spleen is showing normal enhancement. Pancreas, both the kidneys are showing. So, sir, there is a lot of mess in the pelvis actually. So the
Don't
left
worry about
side
it.
of hemiplegic.
No. This
Okay,
is the normal
okay,
enhancement of the uterus.
okay,
I think
okay, sir.
it's the later. Don't
Sir,
worry.
interception. Okay, sir. Liver is normal. Pancreas. Sir, vascularity. I should be concerned about vascularity then. Um, SMA is normal. There is the liver is normal. Where am I getting wrong? So there, so it shows heterogeneous enhancement. I cannot appreciate any focal lesion. There might be a area of hypoattenuation which is seen in the right lobe of the liver, most likely in the segment 7. So
What else?
it what
What else?
okay.
What
Okay,
else?
sir. So the caudate lobe is very much hyper enhancing and showing
What does it mean
enhancement
for
on
you?
these. So it might be a metastatic focus.
What's your final
Uh,
diagnosis?
so interception most likely due to malignant bowel wall thickening and a metastatic focus in the caudate lobe of the liver parenchyma.
What phase this one?
So this is a sir. I think sir, this is an arterial phase. However, the
Arterial.
portovenous phase is
1 second.
so this.
Arterial enhanced hepatic metastasis. Could you tell me the possible type? See how many metastases? The possible
Yes,
type
sir.
of
Yes,
malignancy here?
yes, sir. So
Yeah.
that might be, sir, since this is a, so they are hyper attenuating, so that might be, so the case which you showed earlier, sir, for the pancreas, that was a neuroendocrine tumor, sir, that can be a neuroendocrine tumor with the hypervascular metastatic disease within the liver parenchyma. And so that can be an adenocarcinoma with metastatic disease. Okay.
Why you were in the correct pathway. Small bowel neuroendocrine tumor because it is arterially hyper-enhanced
Yes,
metastasis.
sir.
Say
Yes, sir. Mm.
each word you mention in the exam will be taken
Mm.
against or with you. How could you
Yes, sir.
tell me in the beginning, doctor, this is artery enhanced metastasis, and then, doctor, it may be neuroendocrine or it may be adenocarcinoma.
Mm.
This is not options. I must choose. There is a science. Arterial
Okay.
enhancement, you should talk only about neuroendocrine tumor. Otherwise,
Yes, sir.
otherwise the
Mm.
examiner, there are 6 criteria. My colleagues in Viva, any examiner
Mm.
evaluate you about it. The worst
Mm.
one, you are unsafe.
Mm.
No, you didn't get the finding. Number two,
Mm.
you are unsafe. Number three, I think by I'm started from the worst to the
Mm.
less bad classification.
Mm. Yes, sir.
Number three, you are scattergun.
Mm.
They mention like scattergun. Like somebody catch his gun and he didn't know where is the target. When you
Okay, sir.
give all differential diagnosis, which some of them related and other not related to the vision, really they will mention the candidate is scattergun. After that,
Okay.
candidate can reach the diagnosis, but with
Number cut.
large,
Lot of number cut.
large or يعني too much help. Then less help. Then the last one, candidate gets the diagnosis. Okay, only one got
Okay.
the comment. So take care.
Okay.
Your account, your speech should be accurate because
Yes, sir.
each word they catch in it and mention in the report.
Okay.
Anyone who didn't pass from Viva before, you can ask them for a report of the examiner, and
Okay.
each examiner will mention for each case his comments. I think
Okay.
many of these comments you can use it, you can squeeze some benefit. Okay, thank you, doctor, so much. Small bowel neuroendocrine
Thank you,
tumor
sir.
with hepatic metastasis.
Definitely.
I think in the next and last candidate.
Yes, sir. Good evening.
Sir,
Good evening, candidate. I think candidate
Candidate
number
6, sir.
6.
Yes, sir.
Okay. 50-year-old female patient with menorrhagia.
Shall I ask for control, sir?
I will help you. Go on.
Okay, so I have been provided with the MRI axial view of the pelvis of a 50-year-old female who presented with menorrhagia. I'll scroll through the images and I'll mention my findings. Here in my first scroll, I can see that there are a multilocular cystic lesion which is seen posterior to the uterus. Really, I can't mention its side as it is directly related to the posterior aspect of the uterus. I'd like to correlate with this with sagittal view images. However, for the rest of the findings, can I scroll down, sir, please? Here I can see, yes, the rest of the uterus appears somehow showing heterogeneous appearance of the junctional zone. However, I'd like to confirm this also on the sagittal images. There's also
Doctor,
minimal
doctor,
pelvic
one
free
second.
fluid.
1 second, 1 second.
Yes.
You jump from the major finding to a very less finding. This is important. Why? Because you see, or you told me there are multilocular cysts. You didn't talk about if there are any solid component. What about this ascites? So you must fulfill. Doctor, I want
Okay.
the next sequence like this uh, to rule out any solid component like this. Then
Okay.
keep side finding to the end. Most of the time, the examiner will not care about the side finding, really, because each exam has one or two pathology maximum. يعني, at the worst
Okay. So
scenario, you will have a case of double pathology. What's the next sequence do you want?
okay, sir, I'd like to correlate this with these findings with the axial T1 images to see if these lesions are hyperintense on T1.
Which T1? This is T1. Okay.
Okay, so the right lucum of the cystic lesion show a slightly high signal on T1. This appears to be of high proteinaceous content or hemorrhagic component. So I'd like to see the post-contrast axial fat set images to see if there is any enhancing solid lesions. Okay, sir. So here I can see that the cystic lesion shows a marginal enhancement as well as areas of intralesional solid papillary projections. I'd like also to scroll through the rest of the cuts to see if there is any associated enhancing lesions. Yes, sir. I can see that the fluid appears to be. Yes. Can I stop here in this cut, sir? Yes, here. There is enhancement also seen along the periphery of the fluid, which means enhancing peritoneal reflections. I'm thinking about a complicated type of fluid, which would be probably either inflamed or malignant ascites. So I'd like to, regarding the source component of the lesion, my provisional diagnosis for this case would be a case of neoplastic pathology related to the adnexal region. So I'd like to see it on coronal view to correlate their position in relation to the ovaries.
No coronal view,
Okay.
only axial.
Okay. So I want to scroll more to see if is there relation to the ovaries. Okay, sir. Okay. So I really can't appreciate the ovaries here. Maybe the left one here related to the left side of the uterus.
That's your final
Okay.
diagnosis. That's
Final
your
diagnosis would be, yes, my final diagnosis would be a neoplastic lesion of adnexal origin, most probably mucinous
What else?
Yes,
What
sir.
else? What else?
Um,
You mentioned it
so
may
there is,
be of ovarian origin. What else?
yes.
But do you think, doctor, bilateral ovarian, bilateral ovarian, malignant like cystic lesion and ascites and the peritoneal enhancement, does it mean something else for you?
Yes, this might be also a Krakenberg tumor
Okay,
with the ovarian secondaries, or it
okay.
may
Are
be
you, are you sure?
for
Are you sure this is Krokenberg tumor?
you mean, sir, that it's not of a GI origin? Okay, sir. This may be a disseminated peritoneal metastasis from another abdominal pathology, or
Could
it
you
may
tell
be
me
from
the primary, please? Primary.
from this image. Okay.
Mm,
This may be also a mucinous neoplasm of abyssal origin with the
okay,
peritoneal secondaries.
okay,
It may be a mucinous colonic adenocarcinoma.
okay, okay. Finally, what is the primary?
Sir, I want to do another scan to scan for the primary lesion. I'd like to scan the rest of the abdomen.
No, this is more than enough. What do you think?
Okay, sir, I can appreciate that there is here in the rectum. I think there is here. Yes, in the last cut, the one before this cut.
Mm, yes, here,
Yes, this cut. I think there is
this,
a circumferential neural thickening. No, the one before.
this,
No, no, sir.
this.
Yes, the next one.
Mm, yes. So, your final diagnosis,
Uh,
please.
my final diagnosis would be suspected circumferential neural thickening of the rectum, consistent with rectal adenocarcinoma with peritoneal carcinomatosis and secondaries in the Douglas pouch.
Okay, but this is not the rectum. Why the rectum is here? Follow the rectum. Follow, follow.
So I think
The
this is
rectum is very
overlap.
low. No,
Okay.
this is the sigmoid. Look here.
Okay, sir. So
Follow
that's
the,
why
see,
that's why I
this
wanted
is
to ask
sigmoid.
for a coronal, sir. So thank you.
Okay, your final diagnosis is
My final diagnosis is a sigmoid adenocarcinoma with peritoneal secondaries and with peritoneal secondaries and malignant ascites.
and Krokenberg tumor.
Yes.
Krokenberg
I know.
tumor. By the way, see, this is the ovary. This one. Okay,
Yes,
and
this
the
is the
other
one I
one,
suspected,
this
sir.
one. See, this other one is here. How could you be sure this is the ovary? Follow the
In
vessels.
diffusion. Yes, sir.
No, no need for diffusion or even in T1. Follow the vessels. Just medial to these vessels, always. Even in ultrasound, when we can't detect the ovary, we follow the vessel. Okay. So finally, it was Borkenberg tumor due to cancer, not rectum, sigmoid cord. Thank you, my colleague. Take care from double pathology. Don't panic from any atypical presentation. Don't give too much detail about the finding and forget the other association like double pathology or primary or syndromic association. Keep motivated. You can do it. Thank you for all of you. Let's
Thank
meet
you.
next session. Goodbye,
Thank you,
all
sir.
of you. Thank
Good
you.
evening, sir.
Bye.
Thank you.
And bye.